At this point, you've checked your patient, you have your anesthetic record, you have your drugs filled out in the back. Remember to fill out your drugs appropriately on the back of the anesthetic record, to fill out any blood work results you may have, and also to fill out the part where it says anything about any pertinent history and the reason why your patient is here, which would be included in the master problem list. With that in mind, we have our box that you've seen before with your drugs in it. All your premedicants are going to be in here. We're going to get these drugs. We have a tranquilizer, an opioid, and an anticholinergic. Instead of having to do 3 injections on our patient, we're going to combine these drugs. Just grab a larger size syringe, in this case a 3 ml syringe, and we're going to combine the 3 PreMeds that we have into one. When combining your drugs, you're going to take a larger syringe, in this case a 3 ml syringe, and then you have your drug syringe on a smaller syringe. To combine them, you're going to take the needle off of your larger syringe, pull your plunger back with enough room for all the drugs that you have to combine in there, get your syringe with your drug, uncap that, and carefully inject one into the other. And you repeat this with as many drugs as you have that you want to combine into one syringe. When injecting your patient, you have choices of muscle groups that you can use. It's going to depend on how much your patient is reactive and how much containment and restraint it's going to need. For this dog specifically, I'm going to go for the hind limb, the semitendinous semimembranosus area. Your assistant's going to restrain the dog for you, restrain the head in a way that it can't turn and bite you, and restrain the body so it can't dance around too much. I'm going to grab the muscle group and a simple IM injection. Aspirate before you inject, and we're done. At this point, we have our patients adequately premedicated. We have adequate pre-med response. This would be the time where you administer your antibiotic, the Convenia, and in a way that it will be on board before your patient needs to go to surgery, and it won't stress out your patient any further by giving them another injection before they are amenable to receiving that shot. Make sure you have everything ready to put your catheter in and to intubate your patient at this point. You see that here we have scrub, we have flush. Our T-port, make sure your T-port is flushed before you pick it up to attach it to your patient, your IV catheter, a dry gauze, and your tape. And we're just going to place the catheter. Again, restraint is essential. We're going to clip the area of the cephalic vein. Once the area is clipped, you're going to scrub. Make sure your area is always clean and tidy. This is going to make things a lot easier for you. Get your IV catheter, make sure it'll thread appropriately for you, so break that little seal that it may come with. In placing the IV catheter, you're going to use an approximately 45-degree angle to the skin, right on top of the cephalic vessel, go through the skin, wait for a flash. Advance your catheter. Hold off so you don't get too much of a mess. Make sure your sharps are not in anybody's way, and tape your catheter in. There are several ways to tape a catheter in. There's no absolute right or wrong way. As long as your catheter stays in place, we're happy. You can always ask one of us, what is our preferred method? Attach your T-port. And tape that in. After placing your catheter, you're going to check for patency of your catheter, see if it was placed adequately. Take one of your flush syringes, attach that to your T-port or to your infusion plug right at your catheter. There's blood coming back, and as I flush, I can feel the flow through the cephalic vein. Cap it back up, and we are good to proceed.
So now after catheter placement, we're now ready to clip our patient. If your patient is sedate enough. If your patient is not sedate enough, then we might clip the patient after induction. So Sally is holding this patient. We're going to clip for an ovarian hysterectomy, obviously. Please refer to your notes for clipping for castration. And remember that we want to clip relatively wide. From the xiphoid all the way to the pubis. That way, if we have to extend our incision, we can do that easily. It's important to be gentle as you clip and not scrape the skin. Scraping the skin creates more surface bacteria. That's something we want to avoid. So take your time, be nice and gentle. And make it look nice too. If your clippers get too hot, you can switch them out for a cool pair of clippers, or you can use some spray lubricant on the clippers to cool them down. You'll notice I'm still wearing my lab coat. I want to wear my lab coat so that I don't get hair all over my surgical scrubs. Now, a member of you're in groups, and 2 of you will be doing anesthesia, 2 of you will be doing surgery. Any member of your team can do the clipping. And we don't have vacuums because they're very noisy. And so we'll just have you brush off the hair. And you can use a damp paper towel if necessary. Be sure to put the hair in the wastebasket.
At this point, we've done everything we needed to do out in the prep area. Our patient has been clipped for the surgery. Catheter has been placed. Antibiotic has been given. Now we're going to start the procedure that we need to follow to induce our patients and take them into the OR. This is a critical moment in the anesthetic procedure that you're about to do. Your whole team should be ready for when this patient is intubated to go into the OR, which means you've gotten rid of your lab coats. They are hanging either outside of this room or in one of the lockers. You have your caps properly identified and you have your masks. Your whole team should be ready. Your whole station should be ready. Your equipment should be ready inside the OR. Your fluid should be hanging. Your monitoring equipment should be waiting for you there. Also, remember to clip a spot for your Doppler monitor on your patient before you roll in. You won't have clippers inside, and you all have Dopplers to monitor blood pressure. So remember to clip a spot on the palmar or plantar aspect of the hind or front limb. All right. Once you get ready to induce, make sure you have all the equipment you may need. You're going to need to have a laryngoscope with a properly sized blade and with the light working. You need your endotracheal tubes. I would suggest that you pick an endotracheal tube size and get the size above and the size below, just to make sure that you will have the appropriately sized tube for your patient. The tube should fit in a way that you can put the largest tube with the largest internal diameter in your patient without a traumatic intubation. This patient, I have chosen a tube of an internal diameter of 7 millimeters to use. Make sure you have sterile lube for your tube, a cuff syringe, eye lube, a way to secure your tube, in this case tie gauze, and flush. Your induction agent is going to be in your box. In this case, we have our propofol out here that we're going to take for our induction and our flush. I'm going to place them both here. You're going to get the tube that you chose to use. With these specific tubes that have a high volume, low pressure cuff, I would ask you to lube your cuff with the cuff inflated. That way, when you deflate it, the creases that it caused will be lubricated as well. Deflate your cuff and get ready to intubate your patient. Everything that I need is close to me, is within arm's reach. Remember, you're inducing anesthesia. From that point on, it's up to you to control an airway and to provide support for your patient. You will have an anesthesia machine available to you. We're going to ask that you all pre-oxygenate your patients for at least 3 minutes before you start. You'll have an O2 mask. Turn your flow on to anywhere between 3 and 5 liters and administer oxygen to your patient for around 3 minutes. And you'll do this with the exception of patients that are too stressed. If you're stressing your patient out more by administering oxygen than not, skip it and go for the induction. Pre-oxygenating your patient allows you time. It buys you time to secure an airway before your patient becomes significantly hypoxemic. By pre-oxygenating your patient, a difficult airway or a less experienced person that's intubating the patient can have time to do so without putting your patient at risk. Once your patient is ready, your assistant will position your patient for you. The easiest position to intubate a patient for those who haven't done it a lot is going to be in sternocrecumbency, and that's what we're going to use here. And get ready to induce. I have my propofol in place. I'm just waiting for the 3 minutes of pre-oxygenation to go by, and I'll start my induction process. When inducing your patient, you're looking to achieve an adequate plane of anesthesia that will allow you to intubate. For dogs, a simple induction with your induction agent will suffice. If you have a cat have a more pronounced laryngeal reflex, and they will require either a deeper plane of anesthesia for you to be able to intubate without trauma, or desensitization of the arytenoids. We choose the second option. We choose to desensitize the arytenoids, given that a excessively deep anesthetic plane is not desirable. So you'll have lidocaine spray to use in cats after induction, before intubation. All right, we're getting ready to induce this patient. We have our propofol in place. You're going to inject your propofol slow and steady. You don't want to inject fast enough that you won't see the effects of the propofol, and you're likely to overdose your patient. So it's a slow and steady, constant injection of propofol until signs of anesthesia are noted. They will lose the strength on their necks. They will lower their head. The eyes should rotate ventromedially, and there should be very little jaw tone, allowing to open the mouth and expose the arytenoids. You notice that we're still pre-oxygenating the patient through induction. Muscle tone is starting to go away. Ears are still reactive to the noise, so she's not quite there. You can take the mask off. Once the propofol is in, a gauze will help to expose, to pull the tongue out. You're going to hold your scope with your non-dominant hand. You're going to hold your tube with your dominant hand. You're going to place the blade of your scope at the base of the tongue, underneath the epiglottis, and pull everything down so you lower the epiglottis and expose the airway. Once the tube is in, you secure the tube in place, and your assistant and somebody else that's with you will check for signs of life. Make sure the patient is adequately anesthetized and stable. And now it's critical that we roll in as soon as we can and start oxygen on our patients. All right, let's go. I'll do that inside. I'll do that when I have it attached to the machine.